لايف على اليوتيوب.
على البيج بتاعت حضرتك؟
على اليوتيوب، على اللي هي سنجاب اكاديمي يوتيوب.
تمام.
وبنفس الوقت هو بيكون بيعمل ريكوردينج، وبالتالي بعد المحاضرة ممكن الواحد يعمل شير لللينك، والناس اللي ما قدرت تحضر بتشوفه.
تمام. على البيج بتاعت حضرتك؟ تمام.
على اليوتيوب، على ما شاء الله العدد فيه ازدياد ما شاء الله. ما شاء الله. ها الدكتور علي سرجية اعترف قديش عمره. فيك تحذر دكتور طارق قديش؟ من غير ما تشوف.
من غير ما اشوف يعني
لما
يعني من غير ما اشوف، بكل الخبره الطويله وتاثيره الكبير على اطباء بلده. يعني انا بس برضو اصل موضوع السن ده حساس. يعني علميا ده قرون، لكن نشاطا ممكن يكون مثلا في اواخر الستينات اعتقد، ولا ايه؟
ما شاء الله. يعني الله سبحانه وتعالى يطيل بعمره ان شاء الله واعماركم جميعا. هو 73 سنه.
بسم الله ما شاء الله. بسم الله.
الله يبارك فيه، الله يبارك فيه ويخليه يا رب.
اي والله ما شاء الله
يستاهل الكل.
نعم. ايضا الدكتور ظافر وفائي ما شاء الله. الدكتور ظافر وفائي 83 ما شاء الله.
الله يديمه.
امين يا رب. اعتقد نحن ان شاء الله ممكن نبدا. بسم الله الرحمن الرحيم. السلام عليكم ورحمه الله وبركاته. Welcome everybody and good afternoon, good evening, good morning wherever you are. Most welcome to this new session in Sinjab Academy Glaucoma Club. And as usual, one of the pillars is Professor Tarek Sharawy. Of course, no need to introduce him anymore. He is a very well-known figure. He is a pioneer and superstar in glaucoma, not only in Egypt, not only in Switzerland, but worldwide. So we are lucky to have him on board. And actually, Professor Tarek has a very nice way of presenting. He gives everything in a concise way, systematic, direct to the point, and up to date. The most important is up to date. So today he is going to talk about Preserflo micro shunt. And of course, I would like to thank very much Dr. Munir Atri for being with us and being a moderator of this session, because I am ignorant in glaucoma. I don't know anything in glaucoma, just maybe some names of the medications. So always Dr. Munir rescues me in such occasions. So thank you very much, Dr. Munir. And the stage is our professor, great Professor Dr. Tarek Sharawy.
Professor Mazen, thank you very much for having me. It's an honor and a pleasure to be with you. And Munir, of course, is a very close friend and colleague. I have loads of respect to Munir, and in his own sense, a great star that is budding out in our region and in the whole world. It is really an honor to be with you tonight, and I want to speak about Preserflo microshunt. The Preserflo microshunt is one of the most promising devices in glaucoma, and glaucoma to you, Dr. Mazen, is some glorified plumbing. So it is. There's nothing there that you would find difficult, I'm sure, with your intelligence and width and breadth of knowledge. So Preserflo, as you can see, is a device. It's a tube. The tube is based on the Poiseuille equation or the Poiseuille law that considers the length of a tube and the diameter of the tube to calculate the amount and volume and speed of a fluid going through the cylinder. So it is actually a fluid dynamics equation that we rely upon a lot in glaucoma. And as you can see, it's an 8.5 millimeter long. It is associated with a 70 micron lumen, so very, very thin. You can imagine that this 70 is part of a tube that has a total diameter of 350 microns. The 350 microns with a 70 lumen, it is associated with those two winglets, as you can see here. And the design is very interesting because you have this length that will allow 8.5 millimeter, that would allow for the aqueous to egress the eye far away from the limbus. We all know the problems associated with fibrosis when it comes to limbal filtration. The lumen of 70 micron allows for gives us the opportunity to avoid the hypotony, as we can see with big or with wide lumened tubes. The diameter of the device, 350 micron, is also relatively thin to allow for this device to be included in what people call minimally invasive devices or MIGs. And the winged design that you can see here prevents migration and leakage around the tube. And as you understand, it has no plate. So it's not like a barbelt, it's not like an amide. There's no plate, and avoiding a plate obviously makes the operation much easier and prevents all the complications associated with plates, like, for example, diplopia. So just to compare a little bit the length of the device. So the device of the micro shunt, the Preserflo, is 8.5, as we said. The Zen implant is shorter, it's 6 millimeters, while the Ahmed valve in total is 25, so much bigger, associated with a plate that is obviously inserted more posteriorly. But remember that all those devices are inserted in the subconjunctival or subtenon space, meaning that you are always at the mercy of the conjunctiva that you have to always test and understand before you do your operation. Here I'm using the upper lid to mobilize a little bit the conjunctiva to give me a feeling about if the conjunctiva is mobile or not, if it is thin or not. This is so important before doing the operation. I also have another trick. I give an anesthetic, a topical anesthetic, and then I use one of the cotton buds to move the conjunctiva. I need to see that the conjunctiva is readily moving, and I need to test its if it is thin or not. This makes a huge difference. The primary material that we use as glaucoma surgeons in Mad al-Kham is actually the conjunctiva. So we need to assess the health of the conjunctiva. The last step of understanding the conjunctiva is intraoperative. I do a small snip in the conjunctiva, and then I inject fluid that can be simple BSS or subconjunctival anesthetic, whatever you want. This will give you immediately an understanding of what kind of conjunctiva you are dealing with. Remember, you can do a great operation, and if the conjunctiva is defective or thin or atrophied or scarred, then there is no chance that your operation will succeed, and it will be very difficult to even close the operation. So imagine doing a glaucoma operation and leaving the operation out there with an open sky approach, which will be a catastrophe. Now compare, this is also hydrodissection that I'm doing in an eye that was vitrectomized, and you can see the conjunctiva is really dead, 4 to 6 millimeter around the limbus at 360 degrees. Where can you put here a conjunctival procedure or subconjunctival procedure? The other thing that I would advise when you are doing subconjunctival procedures is to immobilize the eye in a perfect manner. This is a speculum that I have designed many years ago. As I always say, I do not, unfortunately, have any financial interest in the speculum, but I have fallen as a victim of the success of this speculum that I can rarely operate without, because I am using an A2O vehicle to totally immobilize the eye. I use topical anesthetic, cocaine 5%, as a surface anesthetic. And as you can see, we have a great big area for us to put our dissection. Now, we have been bombarded with devices. And I think in the last 15 years, I personally have witnessed and have taken part in the design and in the introduction of many of those implants. And it's very important when we're talking about the PRESERFLO to understand, why do we need something like the PRESERFLO? Well, we need something because what we have is not good enough. This is a survey about the relative complication rates by subspecialty. And you can see that when doctors in a big general meeting have been asked to anticipate or to suggest what kind of relative complication rates do they have in their subspecialty, you can see that the refractive and cornea surgeons really reported almost no complications. The cataract surgeons were a bit more pragmatic. The oculoplastic surgeons were, again, less optimistic. Retinal detachments and retinal surgeons were probably, realistically speaking, about 5% of complications. And then comes the glaucoma surgeons, who have been reporting complications of about 50%. I think the difference here is very dramatic. So what we have is not good enough in the majority, in the opinion of the majority of ophthalmologists. So we also have a problem in glaucoma. We tend to be afraid of complications, so we operate late. We don't operate early, we operate late. And when we operate late, there's an increased rate of complications. Complications become higher. So when complications happen, we as surgeons are traumatized. And next time we are facing the decision if we operate or not, we push the operation even further and further, thus increasing the complication rates. And you can obviously understand the vicious circle here. And true, if you look at severe loss of central vision in advanced glaucomas after trabeculectomy, a paper that was reported by Joe Caprioli and Ann Coleman, you can see that they report a central visual loss in 6% of their cases, because of maculopathies, because of cataracts, because of inflammations, endophthalmitis, God forbids, but 6% central loss of vision after trabeculectomy is obviously something that is not good enough. So we need some new techniques to be able to offer our patients something better. And you can see that now we have all those techniques. We have about 32 different operations, and those 32 different operations, if they are combined together, we can have up to 20,000 different combinations. It's incredible. But we have to try to first make sense of what we have now, all that. So if you're thinking of all that, consider first that there are 4 strategies to drop the pressure. You have a strategy to reduce pressure through subconjunctival filtration, or through suprachoroidal implantation or suprachoroidal filtration, pushing the aqueous into the suprachoroidal space, into improving the conventional pathway through the trabeculum and Schlemm's canal, and finally destroying the ciliary body with whatever we have, lasers or cryo, to be able at the end to close the tap, reduce production of aqueous. Any of those can be ab internal or ab external. So ab external from outside of the eye, or ab internal, we have access to the inside of the eye, mostly through a paracentesis, and then we operate from inside the eye. Now, where does PRESERFLO microshunt lie in this big tree? It is in the subconjunctival filtration, in the ab external, here, right there, occupying the same branch as trabeculectomies with or without express, as shunts, tubes, and valves, as non-penetrating glaucoma surgery, and funny enough, as ab external Zen, because a lot of people now have been implanting Zen ab external, not ab internal as it was initially introduced. So how do we do the operation? Not too complicated. We mark the limbus at about 3 millimeters, as you can see. From there, we create pocket intrascleral, but we don't perforate with this knife. Actually, what we do is we perforate with the needle, and as you can see here, 26G, we are slowly going into the antechamber, all the way into the antechamber, as you can see. And then we slowly and gently thread the PreserFlo into the pocket that has been created, pushing the two winglets inside to prevent filtration around it and to hopefully prevent migration. It is very important to identify your tenon, because basically this operation, it seems that the success depends on implanting under the tenon and not under the conjunctiva. So take your time, find your tenon, as you can see here, and dissect under the tenon and make sure that the exit is coming from under the tenon. The tenon can be your friend and can be your enemy, but recent data suggests that putting the tenon over your filtration site is more productive. It's true that it can provide fibroblastic source, it can create encapsulation. In some cases, it can be responsible for hypertensive phase after tubes, for example, but it is a very strong tissue coat that prevents erosion, and you can use it as a patch tissue. Now you can see the implant is inside, and we can slowly see the aqueous coming out of the implant. I think you will be able to appreciate it down here. It is very slow method of driving the aqueous out of the eye. And what you usually get after this implant in the antechamber, as you can see, you get a sort of what I call a hybrid bleb. It's not a bleb close to the limbus, but it is a bleb that is really midway between what you expect to see around the limbus and what you have with a tube like an Ahmed over barber. It's about 6 millimeters from the limbus. Again, I think this also shows the same thing, the tube and the filtration bleb, which is usually kind of diffuse and not prominent with an antechamber that is fully preserved. You have to understand that those tubes can obviously scar, just like anything that we can do in the eye can scar. The good news is you can still open the conjunctiva, you can still find the tube, you can do some very meticulous dissection, which is kind of easy to do and fun to do. I enjoy these kinds of operations because they're not classic, they're different. We are really liberating and giving a new life. And you see, as soon as we liberated it, aqueous is coming out. So here you can see the aqueous. If I continue further, I'm also dissecting around the tube as much as I can. And the good thing about these tubes is that they continue to function and there's no occlusion of the internal lumen. And then we can basically put some mitomycin, test the filtration, as you can see, make sure that it is immobile and it is not moving, and simply close the conjunctiva. Having said so, those tubes can erode. Here, this is a patient that was that I was looking at, examining with one of my residents, who was very happy to report the pressure is 8 after 2 years, and 8 is a little bit too low. So I kept looking, and just if you can see, it is not too difficult to identify. Your best friend is always to use fluorescein matches, or what we call allumettes, and just a little bit of that. I think it's doesn't need an explanation. You can see actually the aqueous leaving the eye completely, and the tube that is not completely outside, but just a small axis to the outside of the conjunctiva is enough to create erosion. What kind of pressures do we expect with the PreserFlo? Here we have a study, our study actually, that is published, and you can see that we went down from 22.4 for a baseline in a number of 125 cases. Following them up for 2 years, we had only 22 patients lost, but the mean intraocular pressure after 24 months is, as you can see here, about 14 millimeters, which you might agree is not too bad. It is very important in cases like that to look also at the mean number of medications prior to the operation and at 2 years. So we went down from 2.2 to 0.5 millimeters of mercury, which is, again, kind of impressive results after 2 years in those cases. What if we do head-to-head to compare a microshunt to trabeculectomy? Again, trabeculectomy comes out to be the winner, as you can see here, with an 11.2 mean pressure reduction, while the microshunt was at 14, and this is after 2 years. Interestingly enough, if you also look at the microshunt mean number of medications versus trabeculectomy, and you also see that the need for medications is 0.6 after the microshunt versus 0.3, which is half that, and that is after 1 year. And in terms of people patients that were completely medication free, we had a 71% result with the microshunt and 85% with trabeculectomy. Of course, complication rates with trabeculectomy were higher, but these are only complications after 2 years. What we have to consider is endothelial cells. We have Professor Mazen with us, so a world-renowned cornea specialist, and you know that cornea is very precious. Corneal endothelium is very, very precious tissues, and we have in our recent history the introduction of CyPass that was removed after 5 years when we found out that the CyPass resulted in a significant reduction of endothelial cell loss compared to phaco's, and that was basically the reason for which the CyPass was stopped. I have always been very keen about the health of the endothelium, and many years ago, I can't remember really this study was published when, it is covered by the toolbar from Zoom, but it is a paper that I published probably 10 years ago, where we coupled the anterior segment OCT with the HRT corneal module to look at the effect of the Ahmed glaucoma valve on the endothelium. And basically what we could clearly report is that once you put an Ahmed, you will continuously lose endothelial cells as the patient ages. There's no chance that the endothelial cell loss will stop. It is not exponential, but it is progressive. And obviously, an endothelial cell loss that results in a corneal decompensation is a sad story. Whenever it happens to a glaucoma surgeon, it is one of the most devastating and heartbreaking complications that can happen. So I try to do endothelial cell counts to all my patients before I decide on what kind of an operation. You know, the big competitor of the Preserflo is the Zen implant, which is ab interno through a paracentesis. And the question is, should we filter in the subconjunctiva after opening it, or should you filter while the conjunctiva is closed, as in the case of Zen? I personally do not feel that opening the conjunctiva has a huge impact on scarring. I am adamant that the scarring is mainly happening because of putting aqueous in the subconjunctival space. The subconjunctival space is a potential space that is not made to be a reservoir for aqueous. So if you have aqueous there, this basically means that this will be the driving force behind scarring, and not the fact that you open the conjunctiva a few millimeters and closed and healed rapidly afterwards. The big advantage, or the big revolution that will happen in MIGS, is once we are able to use OCTs to map structurally and functionally the aqueous humor outflow. Once we know how to do that, Alex Wang is really one of the big guys that is working on that. Once we are able to map the flow of the aqueous, we will be able to target this pathway in a much better way. What we're doing now is, as we are doing it now, and as we think of ourselves as ultra modern, I cannot but help thinking that what I'm doing to my patient remains very primitive to what my aspirations and what my hopes are for glaucoma surgery. Now, a lot of you will see the guy next door doing this kind of operation, and people will start jumping immediately on doing that. This is the codex of the cognitive biases. One of the cognitive biases is peer pressure. So if you care to look into all that, you will find somewhere here the peer pressure. And this is just to remind you that you should not fall under peer pressure. You should not also fall under marketing pressure. This is the Hydrus implant, recently a beautiful implant, titanium, recently, and very elegant in the way we implant it. You can see we are putting it into Schlemm's canal in a very, very nice and elegant way, scaffolding Schlemm's canal. And this has been bought by Alcon only recently. So you should expect, I have to say, that the marketing machine of a company like Alcon will push hard with a device like that. So choose what you are doing in a clever way and don't experiment with new devices. When the Express was introduced in the Middle East, I was flabbergasted. I was very sad to see so many children with congenital glaucoma actually implanted with an Express, which in my opinion is a medico-legal crime to actually use something like that experimentally on the eye of a child. There will always be the issues of new methods versus old methods. It's our job to do the homework, do the research, increase our experience to be able to make sure that what we are doing is the best for our patients, taking in consideration things like cost, taking in consideration things like comfort. If we can operate patients without blebs, it will be much better, because blebs are associated in a good number of, in about 1 out of 5 patients with issues related to loss of comfort. And do it as we still can do it. You know, here we are doing actually using an amniotic membrane to cover the ocular surface using the Da Vinci robot. So let's try to change the world before robots take this responsibility away from our hands and start operating our patients. With that, I thank you very much for your attention, and I hope that this was interesting, and I'm here available for any questions that you might have.
Thank you very much, Professor Tarek. As usual, very interesting, attractive presentation. Now, although I am not a glaucoma specialist, but I have a couple of questions, especially that we see in some countries that subspecialty is not required to practice. So we may see general ophthalmologists doing glaucoma surgeries, very similar to refractive surgery, very similar to corneal transplants. So the most important is to know which shunt or the indication of the shunt, and as well how to manage complications when they happen. So here is the question. If, for example, I'm not going to do this, but if I insert this Preserflo and I got a complication, how to manage such complication? Is it only scarring so that I can reopen the conjunctiva, or we have other complications, and how to avoid the scarring?
Yeah, we have many complications that can happen. Avoiding scarring relies on you using mitomycin, using clever post-operative period of medications. I put my patients on medication, on steroids, for up to 3 months after the operation, observing in the post-operative period how the implant is or how the eye is taking to the implant. You should not give the patient a follow-up consultation every month. I see my patients every 2 days for the first 2 weeks, and then I'd see my patients every 1 or 2 weeks for up to 3 months. So you should keep the patient close. Putting the implant under the tenon is a much better option than putting it above the tenon, especially because this way you will avoid erosion, which unfortunately happens. And erosion can lead to blebitis and endophthalmitis. It is a clear freeway from outside of the eye if erosion happens into the eye. So whatever comes out, you can also you can also imagine that things can go in. My big question is what kind of complications will happen long-term? The use of mitomycin is associated with endophthalmitis, long-term endophthalmitis in a certain number of patients, issues related to endothelial cells. And if we are going to have a decompensation of the cornea after 10 years, I kind of doubt it, knowing that this doesn't happen with an Ahmed valve, which is much thicker than and bigger than the Preserflo. But this also has to be taken in consideration. We have to take in consideration the longevity of the ages of our patients. We are not anymore operating patients that are destined to die in their 60s or 70s. I have a big portion of my patients in the end of the 90s, and I have a number of patients who have crossed the 100 mark. So with advances in medicine in general, we should consider what kind of a device that will offer something useful for the patient for the coming 20, 30, or 40 years, not for the coming 2 or 3 years. With the Zen implant, I've seen complications like a ciliocoroidal cleft happening. With the Preserflo, I never had a ciliocoroidal cleft, but ciliocoroidal clefts can happen and can result in a very severe and profound hypotenuse. I do not needle those devices. I actually open and clean and retreat with mitomycin and because I think that needling them is relatively dangerous and can result in what I call tube circumcision. This is not something that you want to happen to your tube, to lacerate it or to sever the tube during an operation that is blind. Remember that needling is something that you're doing blindly. So this is not something that I will do. So potential complications are many. Migration can happen. I've seen patients where I put the winglets in the pocket and still the patient rubbed his eyes and they came out. But it is very rare with the Preserflo, with a follow-up of about 5 years in our practice now, or maybe more. Can't remember when I put my first, maybe 7, 8 years ago, maybe, but follow-up is about 5 years now. And I think that I have not seen a single case of a devastating or sight-threatening complication.
Fantastic. Now, another question. You mentioned that this microshunt is a byway, so in and out.
It is not a byway. It's supposed to be unidirectional. It is related to the pressure gradient because it is not valved. So if there is a situation where, for example, you have an encysted bleb where the pressure built up in the bleb is higher than the pressure inside the eye, theoretically, it will go the other way around. But it is not designed for that.
Okay. So it is not a valve.
No. There's not. It's a tube. Yeah. بالعربي ماسورة. It is nothing more than a tube.
Okay. Why not to be designed as a valve? So there will be like a secure one way to avoid, for example, endophthalmitis in case of perforation or.
Why not? Why don't BMW manufacture a car that will use 1 liter for every 500 kilometers? It's the industry. The industry does its job. It does its work. It puts a lot of money and energy into research. But I have to say that in many cases, I think that the industry is sometimes lazy. They go for an easy solution that does not require enough sophistication. And if you're competing with something like the Barvel tube, for example, for me is the biggest example of a lazy industry. They manufactured something 25 years ago. They still do it the same way. They did not bring anything new. So, and people are still buying it. So, and the Barvel implant is not a Hugstride slit lamp. A slit lamp can survive for generations, but a Barvel implant, we should be able to provide something better. We should be able to make use of major advances in science to produce something that is, but Dr. Mazen, you and I, we've been in this business for a long while. If you can do something that you can spend shorter amount in research, and if you can spend less amount of money to produce, and you can bring to the market fast, why in the mind of a businessman spend 10 more years to produce something that would actually be ultra sophisticated? And I can also see their point of view. They want to have, they say, well, we do something like the Preserflo, we earn a lot of money, then maybe our research program will be bigger and we can do something better. But to be very honest with you, as I said in the last few minutes of my presentation, I think that the techniques that we are using in ophthalmology, that the devices that you are using in ophthalmology, I am very surprised when somebody looks at a Preserflo or a Barvert or Ahmed or whatever and looks at it with, wonder and awe, that this is wow. I don't see any wow factor in these devices. We should be able to have something much better now. So we try as glaucoma specialists to push the industry. We try to do our own research. We try to collaborate with the industry. For example, we have in the Polytechnic in Switzerland now the eye watch, which is a step ahead. It is like a kind of a tap that opens and closes the implant to be able to increase or decrease the outflow through the eye. This is the kind of thinking that we have to encourage some real good quality thinking and quality engineering. And it is never going to be only in our hands as doctors. We have to push the industry and collaborate ourselves with engineers to try. Maybe we, in the International Society of Glaucoma Surgery, one of our future projects is to create a wish list, a shopping list, a wish list of what we want to see happen. And this is a wish list to researchers, and it's also a wish list to the industry. We challenge you to produce this. I don't think that they are going to produce something except if we come to them and say, these are clearly our needs prioritized. So we are in the process of creating a big group of glaucoma specialists and cornea specialists to look at creating this wish list for researchers and for the industry.
Great, thank you very much. Okay, Dr. Munir, now the stage is yours, please.
Thank you, Dr. Mazen. Thanks a lot, Dr. Tarek. It's really, really very useful as usual, and the way you present, it's like brilliant. I have almost 5 or 6 comments, and I'm very interested in seeing what you think about it. It's mostly about my own experience, because as I told you before, I started doing this about 2 years ago. I started from the scratch. There was no experienced person in the department before doing this. So I learned from my own experience, in other words. So regarding the surgical technique, I'm currently using mitomycin 0.5%, and I apply it with the corneal shield. I use 3.
For how many minutes?
For 3 minutes. And on top of that, I started only for the last 15 cases, I started injecting under the tenon with the Raycroft some. So at least it just goes more. And then I wash the whole thing out. What I found that this is in a way reducing the, let's say, obviously still very early to say, but it's reducing the angry reaction and possibly getting better outcome. And so far I had no avascular blip so far, no infection, which is good, obviously. So what do you think? Do you use the same concentration or different concentration?
I think you need a little bit more white hair. I think there is a significant pressure, peer pressure on glaucoma surgeons to go for a 0.5 milligram per milliliter and from 3 to 5 minutes. I presume that this drive is coming from London. I have not seen clear evidence that 0.5 is significantly better than 0.3. And I have not seen results at long term for 0.5 versus 0.3. Having said so, under this kind of pressure, I'm also using a lot of 0.5 milligram per milliliter personally, as you are doing and as you are saying. I go for 3 minutes in a case of Preserflo. I don't go more than that because I don't think a Preserflo is the device for very advanced glaucoma. For very advanced glaucoma, I will go for a deep sclerectomy, and I can go for up to 5 minutes. And to be honest with you, Munir, and I have nothing but honesty for the people that are listening to us and to you, I'm not convinced that I'm doing the absolute right thing. At the same time, I'm always worried that I might be denying my patients the benefit of a 0.5 versus of a 0.3. And I've been cornered by my colleagues right and left. I mean, 2 years ago, when 0.5 was starting to be fashionable, I was very much resisting. Nowadays, I kind of gave up a little bit. So I'm more able to use a 0.5. But I can also something else, and this relates to the white hair. I've been practicing glaucoma in Geneva for the last 20 years or so. And in the last 2 years, I've been correcting an enormous number of my blebs. 20 years on, not 5 years, not 10 years, not 15 years. After 20 years, my lists every month will have 2 or 3 reworking blebs, excising blebs, removing blebs. So, and that was with a 0.28 milligram for 1 minute 20 years ago. So I am, I don't know if I will be practicing 20 years from now to be able to, I hope so, but I don't know if I will be practicing to see the results of 0.5 for 5 minutes. And I am skeptical, fearful, and hopeful at the same time. And Mark Sherwood used to say, every 10 years, you should change the place where you practice so that you don't see the long-term complications. Leave it to another guy. Yeah, anyhow, okay. I mean, I'm sorry for the very long answer, but my short answer is I am also using corneal shields. I'm using 0.5 for 3 minutes in many cases. In the severe cases, I wouldn't even attempt it on a Preserflo. I will go for a 0.5 for 5 for a big or advanced case. In essence, I'm not doing anything different than what you just described. Corneal shields, 0.5 for 3 minutes for those cases. So we agree together on what you're doing. And I thank you for bringing that up.
Thank you. I think it's Moorfield team who is suggesting 0.5, and they are moving to even 0.6 or even 0.8.
Yeah, but Moorfields as well had produced 20 years ago studies that says never use more than 0.3. It's a total waste. I mean, I remember the series of studies coming from Penn saying a maximum of 0.3, a maximum of 3 minutes. 20 years on, they're saying go for 0.5 and go for 5 minutes. I would like to see very clear evidence to tell me that after 20 years, the 0.5 is as good as a 0.3 or better, hopefully better, but with the same or lesser degree of complications, not that we are going to massacre the eyes and see it massacre 20 years on.
Perfect. The other thing to mention is, I had few cases with the failed Preserflo. So I did the exact same as your technique. Opened up the conj and obviously tried to remove the scar tissue and then apply the mitomycin. The only difference I found in a couple of cases, the Preserflo was not beading. So I had to insert the rescue suture of 0.9 nylon inside the lumen till the end. It was quite tricky, but then after that, it started beading. So do you recommend doing this?
Munir, I know I will follow your recommendations. I've learned that from you today because I have never had a tube that was not filtering. Every time I went in, it was what was around the tube, not what was inside the tube. But thank you for this trick. I'll keep it in mind. One day I probably will meet that and I will remember you.
Okay, thank you. The other thing, if you had completely failed Preserflo, next step, is it tube or trap?
No, next step will be tube for me. And next step will be a pole implant or a clear path. depending on the age of the patient and the amount of pressure reduction that I want. Probably the pole is safer with slightly, this is my impression, slightly higher pressure. The clear path is my current device for the ultimate device for difficult cases. I will go for a clear path, of course, stented.
Yes, that's great.
I wouldn't go for a trabeculectomy. I wouldn't go for a trabeculectomy, because you go for a trabeculectomy, you will destroy another quadrant, and there's not enough space in the superior part of the eye to keep experimenting. I would rather cut my losses short and go for a tube.
Sure. I mean, I tried both, as you said, and I found tube possibly the best option. Leon, when we discussed during the last meeting, he said his next step is trap. So possibly both options could be reasonable, but your point is very valid as well.
We remember that we have very short memory as surgeons, and we are always influenced by what we have done in the last couple of cases.
Very true. True.
A surgeon's experience can be as good as another surgeon's experience in absence of true science. We don't have a study to compare tubes versus traps in failed Preserflo. They will come, but when it's probably premature for devices. We don't have a head-to-head studies between minimally invasive devices up till now. So for me, it is something that I look forward to seeing. They're not there now.
Only a couple of more comments, almost finished. So I had one case with the kind of very kind of hypotony with choroidal and shallow anterior chamfer, and it happened after high flow glaucoma, like it was pseudo exfoliation with very high IOP. So I operated on the patient. Patient ended up with the hypotony, shallow AC. That was the main thing, and choroidal.
After Preserflo.
After Preserflo. So I waited for a day. There was no improvement, and it was getting even worse. The macula started to be affected. So I gave cohesive, like a Helon GV inside the AC. And then next day, it was completely drained. I was really astonished. How could this happen? Because it's common in the tube, but not in the Preserflo.
Yes.
And then I gave another episode. Again, nothing has happened. So I decided to go in and then try to stent it. However, I said, before trying this, I would just try the dispersive viscode. So I tried viscode, and it worked like a magic. And then I obviously read about it, that dispersive can go into the lumen and stay there. So it can kind of tamponate the lumen for about 2 to 3 days, and that's sometimes all you need.
Absolutely.
So, yeah, do you agree on using dispersive in cases of severe hypotony?
I use dispersive only in severe hypotony, whatever the cause is, always.
Perfect.
It makes perfect sense. And if it does the trick well and good, if it doesn't, then you have to open, make sure that there's no aqueous coming around the tube, which happens sometimes. And finally, stent the tube if you have to.
Great. And lastly, would you do Preserflo for patient who's like -16 diopter?
I don't mind. I have used it in high myopes, and I haven't had any trouble with that. I would use it in those cases because I hate a trabeculectomy in a case like that. I hate non-valved tubes in high myopes, and deep sclerectomy can be a bit tricky because the pressure in the first post-operative day can be between 0 and 6. So high myopes are kind of a tricky situation where you might want to do something like an AMID or a Preserflo, not a trabeculectomy in my hands. Sometimes a deep sclerectomy with some tight suturing of the flap to prevent a lot of aqueous, and putting an implant in the intrascleral space with some reticulated hyaluronic acid on top of it. Tricks just to avoid severe hypotony. Having said so, I've done a lot of deep sclerectomies in high myopes, and it went very well, except if you're doing deep sclerectomies in a vitrectomized eye. This is very, very, very serious. And vitrectomized eyes, the chances of an expulsive hemorrhage and severe hypotonies because of suprachoroidal collection those cases are very tricky, and I would probably go for a vitrectomized eye into an AHMA tube from the start. I wouldn't put anything else because I will be very scared that the eye will have an expulsive hemorrhage.
Thank you very much. Thank you.
Thank you.
Thank you, Munir. Would you like, Munir, to start the questions of the audience, or shall I do
sure.
that?
No, that's fine. Dr. Tawfiq Hakim is asking, how do you make sure that your implant is away from cornea?
Once you have the experience with putting tubes, you know that tubes like an Ahmed or a Barvet, you know that you are usually, or my trick is usually trying to aim my tube as if I want to hit the iris. So never go parallel to the surface of the cornea. Never try to go, in my opinion, in the middle. Try to dip your needle as if you want to hit with the needle the iris. And when you do that, in most cases, you will have the tube midway, not even too deep. So this is the trick that I do. And you know, surgery is about imagination. So you have to imagine the step in your mind before you perform it. Before you perforate into the antechamber with the needle, I take a fraction of a second. I look very well, I think, I imagine, and then I dip. Never, ever go with the needle as if it's a routine or automatic step, because every eye has its own curvature, has its own dimensions. So you have to look the eye in the eye and imagine what you want to achieve. This is, for me, is the absolute step to avoid going towards the cornea.
Great. Thank you very much. Dr. Abbas Al-Fa'ouri is asking, do you recommend Preserflo for a patient with high primary IOP over 30 millimeter mercury?
Yeah, I am not, Basil, I hope that you are doing well, first of all. Basil, I don't care so much about the preoperative pressure, as long as it is for example, about 30% of what I operate in Switzerland are pseudo-exfoliative cases with very high pressures. I don't care. I don't care about the preoperative, except if the preoperative high pressure is because of something secondary to an inflammation in the eye, uveitis, synecdoche, something that is not making the operation a simple one. This, then I would be worried, and I would think about what is the best solution for this patient. But preoperative 30 or not in a pseudo-exfoliative case is fine. I don't mind.
Great. And Dr. Khaled Ayesh is asking, thank you for this great presentation. Do you advise combined procedure with phaco in one stage? Like
yeah. If I do rare combined cases of, let's say I rarely combine a phaco with a tube trabeculectomy or a deep sclerectomy, very rare. But I can combine a phaco with a Preserflo. I am combining a phaco with a hydrous implant, and those are usually for early cases. If it is an advanced case and I need heavy artillery from glaucoma surgery, I will do the phaco first. I wait for a couple of months and then I do the glaucoma. Having said so, it always depends on how well the glaucoma is controlled. If the patient has phaco and glaucoma and the pressure is very high under maximum medical therapy, then I will do the glaucoma case first. I'll do a trab, deep sclerectomy, or a tube. I will wait for 2-3 months and then I will do the phaco.
Perfect. And I think the second half of the question is just possibly, my understanding is for general procedure. What tricks do you suggest to prevent increased IOP post-phaco in patients with long-standing functional bleb?
The problem with phacos after a long-standing functional bleb is that the bleb can scar. So we have to double our effort when it comes to anti-scarring agents. So if the bleb is functioning well and it is a decent shape and size, you obviously can do the phaco, but you have to put the patient on steroids prior to the operation. I'll put them for a week to 10 days prior to the operation. And I will continue covering the patient with steroids, not just for 3 or 4 weeks, but for 2 or 3 months after the phaco in a good functioning bleb to avoid losing the function of the bleb.
Okay. You don't give 5-FU or mitomycin injection on the day?
No
need. Okay.
No need.
So
No. I feel you can push it the other way. If you give mitomycin or 5-FU in the day of doing a phaco, you might result in thinning the bleb, and then it can leak, and then you'll have a sweating bleb and hypotony.
Thank you. That's very interesting. I think the last couple of questions from Dr. Basser Faouri as well. For how long time post-op you advise to use the steroids? I think you answered this. 3 months.
Yes, 3 months.
And lastly, do you recommend Preserflo for young patient, not congenital cases like juvenile glaucoma as primary procedure?
No, absolutely not, because I don't know when I do them at the age of 15 or 20, what will happen to them when they are 80. For those cases, I go straight for a deep sclerectomy. I do not perforate. I preserve the clarity of the cornea and the clarity of the lens. Very important, because the incidence of cataract after deep sclerectomy is significantly less than after trabeculectomy. So I would go, I have a big series of juvenile open angle glaucoma cases, mostly post-LASIK in high myopes, and I've done deep sclerectomy for those cases. Interestingly enough, most of them are coming from the Middle East, and most of them have been doing brilliantly up till now. I mean, I follow them because, you know, I operated them when they were 18 or 20 or 21, and now they are 30 something, and I still keep track of them. I know what happened with their children and their fathers and mothers. It's very rewarding when you operate a congenital case or a juvenile case. You have the royal introduction into a family.
Perfect. I think this is the last question. Sorry. Obviously, ladies usually are first, but here ladies are last. So, Dr. Nuha Al-Fayoumi, is it indicated in recurrent cases?
No, I wouldn't. I think Preserflo has its best chance for as a primary case. I would not, at this stage of knowledge, use it as a recurrent case. Recurrent after a trabeculectomy, after a deep sclerectomy, after a tube, I don't see any sense in that. I've seen people put a Preserflo inferiorly after failed tubes and deep sclerectomies and trabs superiorly. I will never recommend that at this point of time. The potential for infection is high. So the short answer to Noha's question is no, I would not actually recommend using the Preserflo in recurrent cases. And it gives me an opportunity also to salute our colleague, Dr. Nuha Al-Fayoumi from Damascus.
Absolutely. Thank you very much. Thank you, Dr. Tarek. That was really very, very good and brilliant presentation. Thank you for the discussion as well.
Pleasure.
So, Mazen?
Yes.
Back to you.
I'm a listener, student. Okay, great. So we are on time, and thank you very much, Professor Tarek, again, for the brilliant lectures. And thanks to Dr. Munir as well for being with us and moderating the session and doing some discussions. And thanks for all the audience and those who ask questions to enrich the session. And I would like to remind you all that there will be like an additional session in this month, May, which will be the coming Friday, May 20. It is a combination between uveitis and glaucoma. So let's say the topic will be uveitis and glaucoma, what to do. We will listen to both professors, Iman Abdul Latif and Ahmed Mustafa Abdul Rahman. So it will be a very interesting discussion. So I would like to invite you all to be with us. It will be at the same time, 5:30 p.m. GMT, which is 7:30 p.m. Cairo time. And I think it will be 6:30 UK time. So thank you very much again, and see you soon, inshallah. Assalamu
Thank you,
alaikum
Dr.
wa rahmatullahi
Mazen.
wa
Thank you.
barakatuh.
Always a pleasure
you.
to work with you. Thank you very much. Have a beautiful night, everybody.
You too. Thank you. Bye.